Actually,
Hi Partha.
लाइव चालू हो गया है this one.
Hi Mani. Hi Akhila. Hi Navita.
Good morning, everyone. I mean, good morning, good evening for you guys.
Evening. Yeah. Hi. Hi.
Morning to you, Akhila.
Yes,
Good morning.
yes. Nice to
Right.
see you all.
Right in the middle with a good afternoon there.
Yeah.
Nice to see you all.
Hi Mani. Hi Akhila.
So, how are you?
Hi
Hi,
Navita.
Hi, good afternoon. Good evening.
Good
Good evening, sir.
Hi, good evening.
नमस्कार
नमस्कार पार्था जी, कैसे हैं?
अच्छा अब ऑन हो गया ये पे अच्छा आई वाज वर्किंग ऑन माय अदर कंप्यूटर हाँ क्या म्यूट हाँ सब ठीक है हाँ आई एम ऑलराइट हाउ इज एवरीबॉडी
Everybody is good.
राइट नमस्कार निर्मल सर आपसे तो एकदम दिखाई नहीं मिलता अभी
आपको आवाज दिया, बहुत बिजी थे.
आवाज
हाय हेलो किया.
अच्छा
लॉन्ग टाइम नॉट सीन, बट आई थिंक यू आर बिजी.
नहीं मेरा सब ठीक चल रहा है सभी तो दो ठो रिव्यू कर रहे थे सर हेलो मनी
Sorry, how are you?
I'm all right.
It's been a while. Yeah.
Yeah.
Looks like a sunny day there. Is that the
No,
case?
it's been lashing down. हिंदी में
Oh God.
आप हिंदी समझते हो ना?
A little bit.
A little. So we will stick to English. I hate talking in English to Indians.
I can understand when you say.
That's okay. No, I'll stick to English then. I sound foreign when I speak in English. And that's not the intention.
I've been working in Vellore.
Just want to remind everybody that we are live on YouTube.
Yeah. So okay. In that case, we'll stick to English. Yeah. So you worked in Vellore.
I worked in Vellore, so which is sort of North India in Tamil Nadu. So yeah, I manage a little bit of Hindi.
That's very good. Now you asked about the weather, but that's the eternal English question, isn't it? It's gloomy outside. Well, if you want to have a look, my family have gone out for shopping, and I didn't accompany them because it's first of all this Corona thing out there, and you can see it's not at all very nice.
Yeah. It's typical.
Hello.
The usual atrocious weather.
Yes.
Yeah. So that's
Yes, good evening to everybody. Please
Yes.
note that we are live on YouTube, so let us all stick our conversations to the public education activity.
Apologies. Yeah.
right. Yeah.
Hi Urvashi.
Hi everybody.
Hi everybody. Welcome. Good evening.
Good evening.
Hello, madam. How are you?
Who are you calling madam? So I'm trying-
Urvashi Shah.
Okay.
You just joined.
Good evening.
Namaskar, Urvashi ji.
We have 3 more minutes. John is joining in 2 minutes in another seminar.
Biplab? Biplab is joining now or is joining late? Abhishek? So Manchi, are we ready?
Yes, sir, you can begin.
Am I audible properly?
Yes, sir, we can hear you well.
Okay. Namaskar. Good evening. Good morning. आज का दिन महत्वपूर्ण है कि आज वर्ल्ड स्ट्रोक डे मनाया जा रहा है. There are so many programs has been created across the globe to create an awareness on the stroke. So one would like to know, what is stroke? Like everybody knows, heart attack is a brain attack. Brain attack is the right term because when you talk about the brain attack, then you can imagine that how in the heart, when it gets blocked, person get pain. A similar thing happens in the brain, but unfortunately, brain doesn't give rise to pain. It gives rise to many more serious disturbances because wherever it affects the circulation in the brain, it causes the effect and that part of the brain get damaged. You would be surprised to know that nearly 80 million people are suffering from stroke worldwide, of which nearly 1/3 have serious disability and about 50 million dies every year because of the stroke. And that's a serious illness. 7% of the hospital expenses, and nearly every year 71.5 billion is the expenses because of stroke. And I'm not talking about the newer drug which is available to thrombolyze the clot within 3 to 4 hours. You will hear about this for all over, that early intervention, thrombolizing, removing the clot are the newer technology. But once somebody gets a stroke, the 1/3 people get better, another 1/3 would have some disability, and 1/3 are having a serious disability. So 30% patients are disabled, and what we can do for them. And that's what is a serious question. And that is where Indian Federation of Neurorehabilitation, along with World Federation of Neurorehabilitation, has kept this program of a true multidisciplinary team. And I'm not going to answer this, what is multidisciplinary team. We have the rehab specialist, Dr. Abhishek Srivastav, and I'm going to talk to him and ask him, what is multidisciplinary team? And what we are talking about, multidisciplinary team role in a stroke rehabilitation. Abhishek.
The multidisciplinary team is a model of care where all professionals who are working for a specific patient, for a specific diagnosis, they work together, they discuss and do goal planning, they plan the treatment, they do the intervention, they document it, they meet every week, they discuss it, and review the goals and the prognosis and the care accordingly. The whole concept is all people who are working towards the patient work in a goal-directed manner and review their outcomes with regular meetings every week. The team consists of multiple people. There are physicians who are involved in stroke rehab, be a neurologist or a rehab physician. There are neuropsychologists. There are speech and follow pathologists. There are occupational therapists, physical therapists, orthotists, nurses, all work as a team to help the patients with stroke.
Absolutely. So this is जो अभिषेक ने बताया आपको कि मल्टीडिसिप्लिनरी टीम का मतलब है फिजियोथेरापिस्ट, ऑक्यूपेशनल थेरापिस्ट, साइकोलॉजिस्ट, स्पीच एंड लैंग्वेज थेरापिस्ट, other people, orthotic, social worker, neurologist, PMR specialist, urologist, etc., who forms a team to have in the center the patient, to take care of the patient. So today we have in the team, and I would like to introduce each one of them. So we have a physiotherapist, Dr. John Solomon. John is from Manipal University. He is professor, and he's been involved with multiple projects related to the stroke rehabilitation. Welcome, John.
Thank you, sir.
We also have an occupational therapist, Dr. Manigandan, who is based in UK, but from India, and has been working on various activity of daily living and activities related to stroke rehabilitation. So I welcome Dr. Manigandan.
Thank you, sir.
We have neuropsychologist, Dr. Urvashi Shah. She has been a very, very senior psychologist and neuropsychologist, and she's going to tell us about the cognitive rehabilitation, which has been really learned. She's one of those few neuropsychologists in India to start the cognitive rehabilitation. So I welcome Dr. Urvashi Shah. Then we have
Thank you, sir.
speech and solid. Yeah, Urvashi, I was.
Thank you very much. I was muted. Thank you. Thank you very much for including me. Thank you.
Then we have Dr. Akhila Rajappa, and she is a predominant swallowing therapist along with the language therapist, and she is from USA. She's based in US. So she has got up early morning to be part of this webinar. This is par excellence lectures on swallowing. So you all will be benefited by her experience. Welcome, Dr. Akela.
Thank you, sir. Dhanyavad Nanti. I'm very happy to be here today.
Thank you. We have two neurologists who probably are very, very busy today being a stroke day. Both are stroke specialists. One is Dr. Dheeraj Khurana, professor and head PGI Chandigarh, who has been working on stroke for past many years, and I'm sure he must be busy in webinar, and he would shortly be joining us. And then another neurologist with the stroke specialist is Dr. Biplab Das from Delhi. Dr. Biplab Das now is heading at Batra Hospital, Delhi, and he is the one who has started the Be Care Stroke, which is a support organization where the people with stroke join together. So we will come back to you, with Dr. Biplab and Dr. Dheeraj Khurana. So with that forms a team, and there are many other experts here, like Suresh is there, Dr. Pata, the neurologist is there, and then there are many more who has joined. So I welcome all of them. Our program is live on YouTube, and it can be accessed through the IFNR channel, so that people who don't want to be on Zoom or are relayed on the YouTube. So with that, I come to John, and unfortunately at 5:30 I will have to leave for some time. I have been involved with a couple of projects today. There are two international lectures between 5 and 7, one at Brazil and another at USA. So I will in between disappear for some time, where Abhishek will take up. So kindly excuse me that time, though I have sent my recorded talk, but I apologize well in advance for that. So I will come to the John. And John, you know that physiotherapy, everybody will talk about exercise, मैं exercise कर रहा हूँ. It's the 20 years ago, probably multidisciplinary team was never even been talked about, and every burden was on physiotherapists, as physiotherapists being large number in country, more than 50,000, maybe more. The data may be old. So as a physiotherapist, when a patient with stroke come to you with moderate disability, how you approach and what you convey to them on, say, day 1 and day 7 and at the time of discharge? John.
Yeah, thank you, sir, for the question. That's a very important question. So as physiotherapist, I always believe that it's important to give the correct information to the patient, what to expect out of their impairment, how much they are going to improve. And as you said, in case of moderate impairment, so for the first step is to identify the impairment level correctly. So as therapists, we have to ensure that we do the sensory motor assessment well ahead in time within the first 48 hours and categorize them well. And then if there is a moderate impairment, we're going to discuss with the patient about how the improvement is going to be in terms of how much you can expect and how their efforts will improve their ability to recover better. So the idea is to teach them that being active and trying to practice task-based training and regular activity is going to what will cause the improvement. So in the first 7 days, we are going to focus on getting the patient out of the bed as much as possible, not to let them lie down in the bed for long time, and then keep also simultaneously training the caregiver and the patient along with them, so that they get trained, so that when they get discharged, they are able to go and take care of them. So the initial focus is on training the patient sitting balance, ability to stand independently, and teach them what are the risks that are there involved in standing, and so that gradually they can learn to walk. And when they are going to get discharged, now that's where the challenge comes. Often once they go home, they leave everything. So that's where we need to train the patient with strategies that will make them adhere to the exercises prescribed. So we had come up with a project where we identified what all strategies should be there for improving adherence. One, so there's important that the physician emphasizes the need for exercise. The physiotherapist teaches what is the salient task that they have to do at home, and then also give them a schedule that they can follow, give them some videos so that they can see at home and practice, give the patient caregiver a set of log chart kind of things so that they ensure that they do regularly, and then follow them up till the point that they come back and so that we know how much they have improved and modify accordingly.
I think it is very, very important aspect that patient has to be emphasized how to do the correct exercises at home, not only patient, but their caregiver and if the therapist is attending. So that's very well said. And do you also have some photographs or booklet with simple exercises, how to do and what are the precaution patients should take? You know, most of the patient with severe weakness in the hand have the loose shoulder or dislocated shoulder. How do you tell them to take care, and do you give them a proper protocol to follow that?
So we are now from pictures, we are now slowly moving to videos. So we use models itself, our own to show them how to, where to hold, how not to pull, and then ensure that safety for the shoulder so that there is no subluxation, and then teach them simple exercises or activities that whatever level of impairment that they have. So you show them this is the amount of movement that you can do. So these are the 4 to 5 set of activities we want to do at home. So you just demonstrate them, record it, give it to them. Most of them nowadays, more than pictures, I think they more like to see videos and perform it, so they move to that phase.
Absolutely, I agree with you. The modern audiovisual system and mobile phone are the very handy, and it is much easier to give them. Even if they've forgotten, they can check it. Thank you very much. I come to the Manigandan, and you know, Manigandan, there was a time about 10 years ago, 15 years ago, even many neurologists were not knowing that what is the role of occupational therapist. And so I want to know from you is when you think the intervention to be initiated by an occupational therapist, and how you assess and start the things straight away.
So I didn't get the second part of it. I'm so sorry.
So once you are invited, invited to assess the patient, how you take it forward, what are your instructions to the patient that what you are going to do. Your patient will say, "Mera to physiotherapy chalu hai, aap kya karenge?"
That's a very important and interesting question, sir. Thanks for having me here today. I think I'm probably going to be looking at it slightly differently from what we are used to when it comes to caring our patients. So when it comes to occupational therapy, we don't even address them as patients anymore. We usually call them as clients. The reason why we call them as clients is because that is how we need to be treating them, and that's how I see them as. So the reason why I'm saying that all that is because the traditional model of intervention provision is centering around intervention provision as opposed to intervention being delivered in a way that is accepted by the individual who's actually receiving it. So I'm going to stay away from the idea of adherence, compliance and things of that sort. So where occupational therapy is going to be, at least in the Western world, it starts in terms of stroke care, starts on the very first day of stroke itself. So the patient, when they come into a hospital with an acute stroke, the most important thing that is lost is their independence. The most important loss in their function is what we see as the area that needs to be worked on. When I say we, I'm talking about me being a patient, and that's what they want. And therefore, our work starts from day one. That's to answer your very first question. The second question that you're asking about is, how do I actually differentiate my role from a physiotherapist's role? Again, that's a very common question. My simple answer is occupational therapy is similar to physiotherapy in many situations, but then quite different when it comes to the function being the primary focus. So in terms of the care delivery, we will probably be focusing on what our patients want or what our clients want. So there are three things that we look for, which is what do me being a patient want, what is that I'm expected to do on a day-to-day basis, or what is that I'm needed to do on a day-to-day basis. If I can get those areas identified and then assist rather than actually provide intervention in terms of reaching to their best of their abilities in terms of their day-to-day goals is what I would probably be doing.
Perfect. I think many times patients says, why should I pay double? Already physiotherapy is going on. So that's a real challenge. And you have to explain to the patient that what you are looking and trying to help the patient in way of delivery of the services. So we move on to the Professor Akila. How common is swallowing disturbance in the stroke? And don't you think that it is most unevaluated symptom in intensive care and today's early stroke evaluation? And how do we address that?
Oh, that's a great question, Dr. Surya. It is pretty common, actually. You all, I would say, like in the US, at least, we see almost 30 to 40% of the population of acute stroke actually end up having some form of swallowing deficit. And then we routinely screen them as soon as, they have a stroke. In fact, you would all, if they have difficulty swallowing, within 48 hours, actually, we evaluate them and actually make some form of recommendation, either to kind of make them completely nothing by mouth or, start a G-tube on, or, if they're ready to kind of, eat something, we are called upon and we evaluate. So definitely, when you have a stroke, definitely, there are swallowing specific areas that get affected, like, many areas in the brain. And even a subtle lesion can actually result in aspiration. And one thing commonly, which is nothing, aspiration is nothing but food entering the wrong pipe, your trachea, below the level of the vocal cords. And most commonly you see is, yes, patients do cough, and that's when you detect it. But one other thing is, they not, just because they don't, there are other population where they really don't cough. So that's a silent aspiration, which is a high risk. And that's something that goes undetected most of the time. And that's when our role as a speech pathologist comes in. Because if you're not sensing any food going down, the airway, then you're at more risk for developing pneumonia. So we have a very, very crucial role in detecting even subtleties, because it doesn't have to be a very big, large scale aspiration. Even subtle aspiration, trace aspiration, over a period of time can get in pneumonia. So mortality is a risk. So we are called in right away.
My one request would be to you is, we need to create a very, very simple awareness program for even people with caregivers who are with the stroke patient, because everybody wants to feed the patient after the stroke. Ye pani pilo, chai pilo. So we really want to create a small assessment video. Okay, if you have this, don't give this. If you can see this, don't give this. If you are safe, these 3 steps proper, then you could probably feed. So if we can make such simple video, which can be seen by the patient's relative, I think it will help us stopping many complications related to aspiration.
Oh, that's a great suggestion. And I'm sure, we can create that. And I think, the only thing is, we can do it from a general point of view, because again, you want the education to be very generalistic, and the specificity comes in to be referred to a speech therapist. So, but definitely, I think a little bit of awareness and safe swallow and feeding strategies would definitely prevent aspiration and other things. Sure.
I'll come back to you later on. And then I have a neuropsychologist, Dr. Urvashi Shah. Urvashi, the first and foremost question is, when a neuropsychologist should be asked to see a patient with a stroke, and why?
Okay. So that's a great question. First of all, thank you for having me here. Can I just start with first just saying that neuropsychology is one aspect in stroke which is highly neglected, because the cognitive disability is quite invisible and the focus is always on the physical aspects, so, and the language. So it's neglected quite a bit. And therefore we are involved, if I look at it practically, we are not even involved most of the time. It goes underdiagnosed, the cognitive problems, and unaddressed. And we are typically involved only when the patients present with very significant problems. If you ask me in an ideal world, I would like to be involved even right in the beginning, right from the beginning post-acute stroke. Of course, I don't have a very major role there because cognition is fluctuating. We do see a lot of cognitive deficits happening in the acute state, post-acute. And it's been estimated almost that 60 to 70% of the people will have a deficit in at least one domain. In the first 3-6 months, you have a fluctuating picture. But even with that, let me start with that even simple things I found with families, just telling them about, they're disoriented, they're confused when they're in the hospital itself, even in the ICU, how to be around that patient. Even when we tell the families of not being over demanding in questioning them, families are anxious. They keep asking, do you recognize me? Do you know who I am? And they put a lot of pressure on the patient. So even that basic counseling to start with is extremely important to manage the patient. And then, of course, we go on to working with the families right from day one to understand pre-morbid personalities, who they are, their resources. So we begin to plan what will happen next. Then, of course, the key role comes around. I find that I do at 3 months a thorough evaluation. And that evaluation is the goal in neuropsychology, because then we are able to pick up the impairments, whether they are just 1 or 2, or do we have a mild impairment? Do we have this kind of trajectory where more and more domains get involved and then you're going into a dementia? Very important to identify that. It's a mild cognitive impairment. Is it a dementia? Because you plan your rehab accordingly. And then we continue to assess at 6 months and then again at 1 year. That tracking is important to understand whether it's a dementia. The tools that you use are important. Just screening tools don't work. With the screening tools, we have found that majority of the patients are not detected. You need a very good comprehensive evaluation to tease out strengths, difficulties, and then you start planning the rehab program. And understanding if they're going into a vascular dementia where stroke is a big risk is extremely important to identify early risk factors, other things, to be able to then guide the families. And it's a different trajectory altogether. So very important. And mood issues, depression. So that needs to be managed very quickly and early.
I could gather that one is you would want the patient to see as early as possible, right? Maybe building.
Yeah.
And you also said that it is must that at least at the end of 3 months, I should be evaluated thoroughly for the neuropsychology.
Yes.
For the point of view of dementia and mood and behavior.
Yeah.
I just want to ask you one question, which may be burning with everybody. ऐसा कौन सा पेशेंट है जहां पर आप पहले दिन नहीं तो दूसरे दिन तो जरूर देखना चाहेंगे? So give us that these are the patient where they should call you, like a patient who is unconscious, semi-conscious, that you would like them to be start early for the coma awakening. In other words, I'm asking those patients who are in coma or semi-conscious, are you going to start coma therapy right early beginning? So this is what my question to you. And I welcome Dr. Dheeraj Khurana from Chandigarh.
Yeah, so this is a different kind of a question, which I didn't anticipate. But in coma, I mean, you're looking at patients who are really severe in the beginning. And there has been, there's no real full-fledged, what we would say, class 1 evidence for coma stimulation therapy. But just speaking from my experience, I would say that, yes, if we plan a good stimulation, a multi-modality stimulation thing when the person is even in the coma stage in the ICU, then it does seem to help, and at least it gives a structure to the interventions and doing the stimulation on a regular basis. Frankly, I would say our role, a critical role comes in a little later, where now when the patient is about to go home and we're sending him home, then of course all our strategies of cognitive exercises, whether it is functional retraining, whether it is the compensatory strategies to improve their quality of life and get them much more functional in life. And I think I just want to reach out. We have a multidisciplinary team here. I know that many of my colleagues have reached out because unless you address cognition and mood, even in the other therapies, whether you're talking about physio, occupational, or others, psychologically, if the patient is not cooperative, if his cognitive disabilities are there, impairments are there, and they are subtle, he will not be motivated or cooperate in your therapy. So unless the neuropsychological aspects are addressed and we work together and we bring that out, the patient is not really going to respond to any of the other therapies. So I want to highlight that.
Thank you for making that particular point to the multidisciplinary team. And I come to Dheeraj. Dheeraj, I've already introduced you, a very, very close friend of mine, and we have been together for quite some time. Dheeraj, my question to you is that, you have been probably 25 plus year practice in the stroke. You are seeing the patient right in and right out. When you started your first year as a career as a neurologist in stroke, and today in 2021, what are the various changes you have seen in stroke management and how it has really changed the way the outlook of stroke has happened today?
First of all, thank you, Dr. Surya, for inviting me and being here at this wonderful meeting. Well, all I can say, it's a flip side what I'm seeing today. And when I started working in the field of stroke, it was a challenging field to be in. I was actually, what I could say is jeered by my colleagues in a way that they said it's impossible to start stroke services, in my setup, for example, in PGI, because everything was in disarray. Strokes were not considered to be an emergency. And I'm talking of the year 2001 when I finished my DM. And later on, slowly and gradually, we built our systems. So the most important thing which has happened over these years, of course, all the challenges, notwithstanding, how to develop a hospital. I won't go into the details of how hospital systems have to be individually developed. We've all gone through those, birth pangs of a stroke system. What is more important is the new generation of neurologists who are now coming up. They are getting a very good level of training in their training years, and they are coming well prepared to start a stroke system. And that was not the case when we started. We had to self-train, or maybe a lot of my friends and colleagues, they went for international fellowships and then started programs here. And it was a big challenge to make your colleagues understand the importance, chiefly the radiologist and the emergency systems, to make them understand the importance of treating a stroke and to pick up a stroke early in the phase of stroke. So that was the biggest challenge, which has now become common knowledge that strokes have to be treated. They have to be picked up as early as possible. And talking of the area that we are discussing is rehabilitation. And there was hardly anything beyond physiotherapy at a certain point of time. And we have, I would say, evolved hugely in the field of rehabilitation. And people have started recognizing the importance of offering rehabilitation at an early period, not only at an early period, also how important we have now evidence which is accruing that rehabilitation can continue lifelong and is beneficial. People should not stop the rehabilitation at any point of time if they don't achieve their goals. So goal setting and rehabilitation teams, although still a very big unmet need across the country, very few places do we get very good rehabilitation, but that's an evolving thing. And that's the most heartening thing of a very high level of understanding about stroke. For example, we have this huge group today who knows that, how stroke treatments are important. It was at that time a rarity of people to start, picking up stroke treatments. And we called them the armchair neurologists at that time, that people were sitting back, neurologist was waiting for improvement to happen, nothing to be done. Now it's no longer that philosophy, and it's a highly active, I would say, hyperacute, so hyperactive, that goes side by side, hyperacute treatments and hyperactive stroke physicians. That's a new breed, I would say, the new breed of neurologists, the highly active. And of course, the most recent development is a new breed of stroke interventionists and neurologists going into intervention. Biplab here is one real classic example, who is a very successful and a talented neurointerventionist, and so on and so forth. There's so many across the country. So these are a big change which has happened right in front of our eyes, I would say.
Thank you, Dheeraj. You have put it across very rightly, and I was going to come to the Biplab only. Biplab, I've already introduced you and your new venture to the Batra Hospital now as chief. So Biplab, to add on to the Dheeraj, how do you see major challenges in stroke care in India? Unmute yourself, Biplab. You are muted, Biplab.
Okay, right. So I'm saying good evening to all. Good evening. So now, am I audible, sir?
Yes, yes.
Yeah, thank you. So it's always a great pleasure to talk about the stroke. And thank you, Dheeraj sir, for saying so nice about me. Okay, so the challenges which is coming is real, actually. The challenges in India, Indian subcontinent, especially if you look into, and what I find, or I think you will also agree, is two-way. One is the stroke awareness. The challenges in India and Indian subcontinent is stroke awareness, and patients or public or a layman who is having a stroke or his family members is having a stroke, the reaching within the golden time is a challenge, because the awareness is so poor. And you wouldn't believe the last 2-3 days, the number of patients which I'm getting here, more than 90% patients are out of the window time. So this is happening in metros, and you can see what can happen in the other places as well. So this is the first challenge, I will say. If you divide into two, I mean, like one is the public system and another is health system, which is there. So the public system, we need to have a proper way of, incorporating all social media stuff, so that we can work in ways, and we can make a layman or a person what is the importance of knowing the symptoms of early symptoms of stroke, so that they can reach hospital in time, and which can give it lots of difference as far as outcome is concerned. So that is number one. And number two, health system. So if you look into the health system, so we really don't have that a comprehensive way of connecting a peripheral either rip or shift sort of system, where we work as any patients who are having a stroke in the periphery, they can be started thrombolytic care, and then after that, that patient can be shifted if needed to this way center where a thrombectomy can be done. So this is where we need to work, actually. Although this drip and shift model is already in place, Dr. Khurana started working on that one, and we are trying to do same thing somewhere in Guwahati or Northeast. But it's not a comprehensive one. Something which is of a more larger in a proper way working will be wonderful, actually, and will really help the public. So these are two things I feel, really great for us as far as India is concerned. Right, sir. Over to you.
Absolutely. Thank you very much, Biplab. So we finished the first round of response from the multidisciplinary team. I come to the Abhishek before he takes over from me. Abhishek, as soon as a patient you are asked to see a stroke within, say, 24 hours, young man develop the right hemiplegia and the aphasia. Everything is in disarray. He's a high executive person working into the field, or maybe a VIP, it may be a sports person, or maybe a businessman. How do you tackle this patient? What do you say? How you convince them that what you're going to do? Of course, the neurologist has already given them thrombolysis, started the treatment. So now, how do you tell him that how you are going to work on it? I think this is important for public to know that how we deal that? Abhishek.
Nice question. So it'll have three components. One component is the evaluation. So I will try to evaluate all its facets, all different domains which are affected in a short way, and then involve the multidisciplinary team to work on that. That's my first thing I will do. Second is every family will want to know about the prognosis. So to prognosticate realistically what is possible in short term and in long term. So I'll tell them this is what you can think of achieving in 1 month's time, in 3 months' time, or 1 year time. And third is how to plan the treatment. They want to know what treatment will be offered if you stay for 4 to 6 weeks. So I will tell them if you have significant deficits, you have to at least do an inpatient rehab first. And what are the components of inpatient rehab? The competent multidisciplinary team, you have to tell them in detail, and then tell them about the continuum of care concept. So you do an inpatient program, you have these goals for the inpatient program. Once your tracheostomy is out, once your RT is out, you can go for outpatient program. Once you're able to walk, you go for a daycare program, for example. So one first important goal is evaluation and give work to the field team to work with them. Second important goal is to prognosticate. And third, plan the treatment and make patient and family aware of what we do in the next 4 to 6 weeks.
Absolutely. I think it is very crucial that patient and his family being explained and told how we are going to work. And if the team come together and explain, it will make a lot of impact and everybody knows what is to be talked to the patient. Very crucial. John, I'm just want to have a little bit chat with you. And, you have been in physiotherapy and department for more than 20 years. What do you think that in last 10 years, the rehabilitation from the angle of physiotherapists has changed and how satisfying it is? Because what you were doing 10 years before and the result and what you are doing today and the result, how they are gratifying to you?
Yes, sir. As any other profession now, I think a lot of change has happened in the last 10 years, including in physiotherapy. If we look at the practice 10 years ago among physiotherapists, there was still a lot of belief in the passive techniques that were being used. And that has been traditionally taught to us in the curriculum, and probably that's what was even implemented and probably being implemented in some other places as well. But what we now see in the new generation physiotherapists are that they are ready to take up or practice evidence-based practice. So the major change that we see in the present physiotherapists are that, or in general in rehab professionals, I would say that they go to evidence. They look for which are the aspects that have enough evidence, and then they start implementing that. So that was a major gap. There was a major change. So it was always a textbook method earlier, but now that has changed. Second thing is that I see a lot is the way now the interprofessional team works. I feel many of the times we all worked in silos, but now I see in many places people come together, discuss, work together as a team. And it's not just in one place. So even in small cities, they come together as a team. At least even if they're not located even in the same place, they at least form a group in WhatsApp or social in their own way, and then discuss about a patient and come with terms to make a decision. So, and the communication is much faster than before. So 10 years ago, for me to approach another doctor, or even it used to be so difficult for us to go and talk to them, take appointment, and not anymore. Now people are available, people are more open, and there is more discussion among the rehab professionals to decide and discuss with the patient, the client, and then deliver a proper, better evidence-based practice. Even the training methods have changed. Training methods, what we taught in the college has changed compared to what it was 10 years ago. And we see that the new age professionals know the importance of documenting what are the important standardized measurements that has to be put up in a patient's file and records so that they can go back and check these things. So I feel a lot of good change that are happening in across the professionals, and we see an improvement in standards. But there is still a long way to go. But I think with especially like IFNR working towards training, regular training programs that are happening and many people attending it, we see a change definitely. So I think that that's the major change that has happened in the last 10 years, I would say.
Perfectly all right. And thank you, John, for pointing out this. I'm by my side, I'm on the WHO organized WFNR stroke day with WHO. The lecture is going on from Alexander Rochi, and he's been also talking about global estimated need for rehab for people with stroke. So I think it is very important, and maybe some of our audience would be in the WFNR session also. So I come to the Manigandan, and Manigandan, I think I want to know from you that how the family is important. How do you deal with them when you see a patient with stroke, particularly with hand functioning and other activities?
Right. Yeah. Thanks. That's an important question. Yeah, it is very interesting question because a family is something that is given a lot of importance.
Your voice is a little bit breaking, so could you come near the speaker?
Do you hear me now? Okay.
Yeah.
Yeah. Thanks. Yeah, I was just saying, like, India is a country which gives a lot of importance and value to the family system. I think that is the key potential that we probably need to be tapping into as a resource. Like, for example, India has a lot of value placed in the family system, as I said earlier, which differs from many Western countries. And I see this as an opportunity. I would like to give more importance to families of people with stroke than what is offered today. So unfortunately, we do not give that kind of a value generally. So the family's role becomes invaluable for people with disabilities, mainly because they are with the client most of the times, and that's probably what I'm trying to pick on. So your question as to how a family can be involved, I'm going to see this as two-pronged approach. So when we are going to be looking at a family getting involved, I think it is important that we probably need to be understanding that we need to be giving them that space for them to be getting involved. So the first thing when I'm looking at as a comprehensive stroke care, involvement of family is central to the comprehensive team that we are talking about. So we've been talking about multidisciplinary team from many viewpoints, considering very many professionals. But I think the family is the central part. So in terms of giving information, I know I think somebody was saying about how important information sharing is. I'm going to say that from my experience as a caregiver. My mother had stroke a while ago, and being a reasonably knowledgeable person in the field of stroke, having enough probably reasonable access to healthcare system, enough finances to put it that way, I still had no support, literally no support. And that is probably where I have to be saying that the professionals need to be a bit more open, and the attitude needs to change slightly in terms of involving them and giving information to them. And with that, we will bring a whole lot of changes. Like Dr. Solomon was saying earlier, a whole lot of things have changed now involving active involvement from patients' point of view. So active involvement will happen only when they want to do it. And that they is dependent on the patient with the family, and therefore giving them suggestions is probably the approach that I would choose, as opposed to any activities that could be brought into their day-to-day lives will be practiced than a simple movement in terms of, say, let's say, you need to lift your arm 10 times. That might not work, but I may use my hand a lot more if I have to be putting my dress on. And that's probably what I would incorporate and encourage my family to kind of give them that option of doing it themselves independently.
Thank you for bringing that point, Manigandan, and I think it is very important. So I move from family to community, and Biplab, you are there, and do you agree that stroke awareness is crucial for the community? And do you organize, and I think today you had organized the cycling. I remember 2 years ago doing it in Guwahati with you. I don't do, but I ran 10 kilometers for stroke people today. I can only walk, so I walk 10 kilometers to support your cyclathon. So tell me, how does it bring a difference in stroke care by doing your activity? Of course, it keeps you healthy. There's no doubt about it.
Yeah, so we are trying to involve a different group actually.
Biplab, your voice is I think some connection issue with the Biplab. So
Now fitness actually. So
Biplab, we were not able to hear you. So could you re-say something? Your mic is unmute yourself, please. Hello. I think some technical issue with Biplab. So while Biplab manages his audio properly, I will ask Akhila a question. Now, the patient you see with the stroke, and it's probably maybe a Wallenberg stroke who doesn't have much of motor weakness. He's bit otherwise healthy, and he suddenly have only difficulty in swallowing, and he has been treated for nearly 6 weeks to 12 weeks and not yet shown any improvement. How do you talk to them, convince them that this is just matter of time, and what effort extra you can convince them to do? So I'm talking about those difficult swallowing problem patient who on the admission until discharge still continue to provide either RT or PAG or whatever.
It's a great question, Dr. Surya. I think, as you all know, Wallenberg syndrome basically affects the brain stem, which is the medulla region where actually the swallowing, central pattern generator is, where you're kind of initiating a rhythmic action of swallowing. So that's actually most of the time it results in severe dysphagia. It's kind of very, very challenging because it targets all the cranial nerves are affected. So when you start off something, when you see this patient in acute care, I mean, you kind of tell them like, yeah, we have to start. I mean, definitely you do with the G-tube and start with alternate means of nutrition. But then you also kind of start working on their swallowing, and you kind of talk to the family and tell them like, this is not something like it's permanent. You can actually, over a period of time, you can work on improving swallowing mechanics, but it'll take time. It'll be a combination of a teamwork with caregivers and constant rehab, maybe over a period of 3 to 6 months, sometimes even a year. I actually work with a patient who's 2 years post-stroke, and we have, kind of worked from being on a G-tube to, kind of having some form of recreational feeds. And then now the patient is on some of an altered diet with supplemental nutrition. So it took us 2 years to be there. And then in between, as you know, swallowing recovery takes a long time. If the rehab was not intervened, again, this patient probably would have been on a G-tube forever. And then you end up also dealing with pneumonias. And on top of that, you also work with the medical team to kind of always work on dilating the esophagus, because that's one issue these patients have constantly in opening the esophagus and, getting the food down. So you work on dilating it. On top of that, dilation alone doesn't help. You have to work on rehab as well. So So it takes a lot and tons of I mean, they say in order to be be good at swallowing, at least it takes 10,000 hours of practice. So that's kind of what I would actually advise the caregivers and the patient. Recovery doesn't happen overnight. It takes time and it takes effort and it takes exercise. You have to believe in swallowing exercises. You have to have these muscle systems recover and and then continuous practice is what is required. And, you have to work with a team. You have to work with a whole team of doctors and therapists and all of that, and also keep mobile at the same time. And definitely the role of PT and OT is very, very crucial, because as when I'm trying these trials of swallow trials to make this patient get better, but you do want to work on pulmonary clearance to make sure that they're safe and, they're not getting pneumonia. So definitely mobility from a PT perspective or an OT perspective in terms of overall activities of daily living. So it's a very interdisciplinary approach.
Thank you very much, Akhila, for highlighting that. Biplab, are you there to answer the community issue?
Yeah, sir. Okay, so interesting. So from changing to something of life. Yeah, today morning we had one cycling event, which is cyclathon we had from Batra Hospital from South Delhi. We moved around Lotus and then came back here. So this sort of event is being organized to, not only take the message to the people, to the mass, and this is we are trying to involve more enthusiastic young guys and children, and doing so we hope because we exactly don't know, we don't have the data how much it has really changed as far as the stroke awareness is concerned, how much this has turned into reality. But it's definitely going to help, because we see that young guys are very actively involved, and they definitely will share this message to somebody of their dearer and nearer one, and probably this is going to help. And of course it is something not only for the brain, and it's going to help in terms like for heart or as a health being. So we have been regularly doing this one, not only in this Delhi NCR park, as Sar was also mentioned. Years back it was in Guwahati. This time also we planned, but because of pandemic, all sort of things, this is not happening. But I think this is the one way where we can connect to the community, to the layman, because people are in young generation, they are very much connected to getting fit and they're looking good. So if we can connect either in cycling or some other health fitness sort of group and take this message to the mass, to the layman, it might help us actually. So this is one of the way of doing that one.
Thank you, Biplab, and I think you are doing a commendable job, and I have been part of it, so very well done. So, Urvashi, I come back to you. Now, the mood and depression are very common, and how do you interact with the team as well as with the patient and caregiver to emphasize that it is very important that this has been taken care of, so that the patient's involvement in the therapy and overall improvement could progress?
So I think there's something we need to understand about mood, depression, not only with stroke, but in India as a concept. After stroke, we do see a lot of patients go into depression. But when we think of depression related to stroke, there are two components. One is, of course, the neurobiological component, that you've had the stroke, there has been a brain insult, and the whole neurobiological aspect, which leads you to a mood disorder. But on the other aspect is also the psychological reaction of how people respond to having now a disability, of having an impairment, of becoming dependent, and those psychological factors and the family dynamics which come into play. So there are these two components. Very often, also another important point before we go ahead to talk about this is to understand that in India, we have found that when we talk about depression, people don't come forward and say that the person is crying or saying, I'm sad. Depression comes in the form of somatization and somatic complaints. So if we get complaints of somebody becoming irritable, or behaviorally, he's behaving differently, or he's snapping a bit, or he's complaining of aches and pains, that is a red flag for us. We pick it up from there. Very rarely you will come across people coming overtly and saying he's crying all the time, or he's saying he's very sad. There's a tendency to hide that. So it's very important for us to first educate the family for looking at the signs. What are these signs that they should look for, which indicate that there may be a depression, whether it is sleep, other factors, and also tease out the components which are a psychological response to the situation and how much of it could be like an endogenous major depression happening because of the condition. Then a combination of pharmacotherapy with the counseling, of course. So pharmacotherapy does have a role, but then cognitive behavior therapy, CBT, counseling with the patient, of course, and the family and the whole family. I'm not talking about the immediate spouse or anyone. You have to bring in, because there's so many family dynamics that come into play when a person has a stroke. And also the guilt. I found that with our patients, a lot of them talk about the sense of guilt because their families have become overburdened. In India, as we were talking earlier, the burden comes on the family. We don't have centers. The families do everything. And the patient, when he's watching the family do all these things, financially, they are drained, the time, the energy, they feel terribly guilty, and they are very upset, or there's a lot of sadness related to that, which we need to address, and how to handle the whole family dynamics. So there's a huge amount of work which we begin right from the beginning, and it may go into even a chronic time, like sometimes even a year later, 2 years later, we'll have issues.
Thank you, Dheeraj. Talking about the neuropharmacotherapy and stroke, I'm not talking of early treatment, what you have been doing. Dheeraj, are you there? I think Dheeraj is a bit occupied. Dr. Dheeraj Khurana? Yeah.
Yeah, hi. Sorry.
Yeah, so we are talking about, Urvashi put up a point that, pharmacotherapy and role. So, you are, strokeologists, start the IV thrombolysis, start this therapy, remove the clot, patient get better. What are the other drugs you can tell the patient that, okay, we are going to offer you this? And these are some of the important therapy which can change not only, what I mean is things like botulinum toxin, antispastic drug, mood elevator. So what are the real role you think in a stroke? And is that for every patient or some patients?
Sure. Yeah, that's a very, I would say, pertinent question in relation to not only improving the outcome, but also preventing a stroke. So the first and foremost principle would be to offer the stroke preventive medicine, because we need to prevent the second stroke. So the option between antiplatelets and anticoagulation in the right patient, that's first and foremost. And every patient across the board should be receiving statins. So I'm reiterating the fact because these often get missed. So statins and antiplatelets, of course, is mandatory, and risk factor control, which would mean antihypertensives and anti-diabetic, maybe orals or insulin. So leaving apart the secondary prevention part, if we look at the other medications which are evidence-based, there were a lot of studies, and recently we heard of the SSRIs in stroke. It's been well talked of. So how are SSRIs useful? The earliest trials which came up, the FLAIR trial, I believe, for fluoxetine, showed very good, very encouraging results for motor recovery. But when we had a recent phase 3 trial, and this did not show really major improvements in the motor recovery, but yes, there were improvements in post-stroke depression, which again is a very common accompaniment. Post-stroke depression often gets missed, and people, if not properly treated, also very, very strongly influences their outcomes in rehab too. So one needs to be careful about treating post-stroke depression, and SSRIs may have a very good role. And indirectly, you may improve the motor recovery. Another thing is post-stroke pain. Again, a good number of patients, not only just thalamic strokes or thalamic hemorrhages, even cortical strokes, MCA strokes, a good number of them do tend to have post-stroke pain, and that again may respond to SSRIs, SNRIs, or maybe blockers like pregabalin. So those again need to be considered. So these should not be points, these should not be forgotten areas. And thereafter comes aids to rehabilitation. So there are certain aids to rehabilitation in terms if the patient goes on to develop spasticity, and that may not happen in the early phases of this recovery of stroke. It takes a few weeks, maybe a week or two, when the earliest element of spasticity starts showing up. And definitely for spasticity, we should give a trial of baclofen or basically anti-spastic agents. Could be baclofen or the other available anti-spastic agents of various mechanisms which are available. Apart from that, there'll be a patient who would be a candidate for botulinum toxin. Now that needs to be identified usually in conjunction with a rehab team, and if the physiotherapist who's been working on the patient does find increasing tone in a certain set of patients, a certain subset of muscles, especially the hand muscles, or tightening of the muscles, which may restrict rehabilitation, in terms that even if you offer physiotherapy and continuous exercises, that may not work as much till the time you release the spasticity, and focal spasticity can be very well relieved with botulinum toxin. Another, apart from the pharmacotherapy, it reminds me, we should offer sometimes patients in the right appropriate selected patients FES. FES may sometimes be useful and aid in the rehabilitation process. Apart from this, one thing I really don't encourage much is the use of the neuroprotective, so-called the paracetam market or the citicoline market. Zero evidence has been there, and I really don't believe in or even promote anybody to use or encourage anybody to use any of these non-evidence-based protectants. There are some neuroprotectants, as is true for all the clinical trials in neuroprotection. They have early stage clinical trials seem to be positive, but finally phase 3 clinical trials still now have proven to be negative. Some of them are in the pipeline, and let's hope if we get good results, we may be able to use some neuroprotection. But till date, no major neuroprotection protectant agents have not been proven to be of benefit, and all they do is increase your burden on the patient by increasing the costs of treatment, because these are very expensive drugs, and instead of using those, the patient could in fact spend on rehabilitation, which is 100 times, I would say there's no comparison, is a million times more useful than using neuroprotection. So apart from these, I believe these are the most effective treatments can be used, and there have been some evidence in aphasias where we could resort to using donepezil and even memantine in certain subset of aphasic patients, which may aid, and there has been some effect which is seen, although not a very robust response, but may have an effect in the recovery. And beyond this, of course, there are so many other measures which have been now being studied. I won't talk of those, the rehab measures, but amongst the pharmacotherapy, these are the most important ones I could think of. Botulinum toxin definitely needs a good patient selection and should be started early, especially patients who start getting tightening in the ankles and start developing wrist contractures, and so on and so forth. I think that would be it.
Thank you very much, Dheeraj, for highlighting all the pharmacotherapy. So we have already done with the 2 sessions, and now we got about 25 minutes more. So I will have a last session. So this 3rd question is coming up, and I will start from the John. So John, what do you think that next 10 years, like how you have seen the changes in past years, how in next 10 years, role of physiotherapy for stroke rehabilitation would be, and what you expect, how you are going to deal human touch, robotic, or hybrid?
Yes, so thank you for the question, sir. And really, I think the next 10 years, there's going to be a major role of technology in the way we practice. And I think I would first take up probably tele-rehabilitation as one aspect, especially what this pandemic taught us. We saw many therapists taking up use of tele-rehabilitation to approach stroke patients and other neurological population. But still, we see that there is no clear clarity in how to implement it, how to assess, how to implement it. So I think the subsequent years, we would probably see more studies and eventually guidelines on how we probably have to use this technology in delivering an effective treatment. The second subsequent things are the use of mobile phones, gadgets, virtual reality, and as you said, robotics. So these are some of these technological interventions will play a major role, is what I think. And we already see a lot of uptake by the therapist for using this. And even the patients have in certain, they have where they are able to afford it, where they experience, there are uptake of these technology-based interventions. So one aspect is that eventually we are going to move towards more technology-based interventions in the next 10 years. Second is the care pathway. I feel the care pathway is something that is probably we can expect it to change a little bit from what it is right now. Right now, there is there is a short admission, and after that there is a break in the care and sometimes home therapies, and then it lasts for a few weeks to path, and there is no clear pathway. And I feel that would eventually change with more awareness and more accessibility that will increase. So we can expect a longer care pathway and transiting the patient from the hospital setup to home and community setups is something that we could expect in the near future. So the third aspect I expect in terms of physiotherapists to dealing with stroke patient is to use of even non-invasive brain stimulation that has been becoming more focused in nowadays. And the next 10 years, we may have more guidelines. Again, we see positive results and trends coming from TMS, and there are many studies happening with transcranial direct current stimulation, though not have come into the guidelines yet. We don't have enough evidence, but there are positive results that are coming from these studies. So we will see therapists using motor priming techniques as an adjunct or in the initiation, and see active therapy techniques to improve motor recovery and have a clearer pathway. So in 10 years time, we would see probably a better implementation of physiotherapy as well as other rehab professionals, therapeutic things better in the next 10 years is what I think so will happen.
Thank you, John. And here now I will request Abhishek to take the further proceeding, because I have to be in Brazil for question answer session for next 15 minutes. So you'll have to excuse me. I will come at the end. Abhishek, will you kindly take over now?
Thank you, sir. So Mani, will take it forward with you. How do you think the use of technology in achieving comprehensive stroke care is feasible in low-income countries? Is it feasible in Indian setting, or it is still a Western concept?
That's a very interesting question, and thank you for that question, sir. So I'm going to follow up what Dr. Solomon was saying earlier. It is exactly the future going to be. So in my opinion as well, like, it is going to be a lot more prevalent in terms of the usage, in terms of technology-based interventions. So active therapy is the way forward, and active therapy requires constant support, and constant support is practically impossible to have in a hospital-based settings, and therefore it's got to be transferred to a home care environment. So in a home care environment, the biggest issue is what level of support can an external person, somebody like us, as a professional, could offer. And that issue is being tackled reasonably well with the tele-rehabilitation protocols. And it is still a very early stage. However, the interesting part is one good thing that came out of COVID-19 is nothing but the therapy provision, rehabilitation provision. And I think it is, in my opinion, it is certainly possible in a country like India, for example. That's because I've lived in India. I've lived in many Western countries as well. And in spite of all that, all I could see is that the technological growth in a country like India is exponentially growing, and it's at a very fast rate, I must agree. And that kind of a rate, I do see next 10 years is technologically driven. I was actually saying in my previous question that involving family as part of the core team, if I can expand that a bit further, I would probably think it is important that we have technology professionals such as engineers or information technologists as part of the core team if possible, and that would certainly solve some of the issues that we are facing currently, be it the protocols that Solomon is referring to. All of those I think is quite feasible and doable, certainly within the next 1 or 2 decades at the max in a country like India.
Okay, thank you, Mani. Akila, we just changed tracks. What are the common speech and language problems you see in people with stroke? That's one. And second, how technology is being used by SLP to provide remote care?
Great question. I think, well, yeah, I think it's one thing is stroke. Stroke affects different parts of the brain, and the brain is the one that controls major of functions like speech, language, and swallowing. So people with stroke definitely can have something called aphasia, which is loss of language, which they can either they cannot understand a person talking, or they themselves cannot express. And another common thing they can have is something called dysarthria, where they're actually the speech motor systems that are responsible for speaking well, breathing well, and kind of enunciating your words clearly. All of those systems can be impaired, and then that's one other common disorder. And then I said dysphagia is something very, very common. Again, almost 40 to 70% of the population can have, where they have difficulty swallowing, because brain does control all these functions. So what was the second question again, Dr. Abhishek?
What is the role of technology or telepractice in SLP in stroke care?
Yes, as you can see, definitely, just like I would just piggyback on what Dr. Manigandan was saying, COVID really showed us like tele-rehab is possible. And definitely we can, what we are seeing is, irrespective of whether it's an aphasia rehab or it's a dysarthria rehab or swallowing rehab, we've kind of definitely all of these things can be delivered efficiently via telehealth, and then the thing is, if you can deliver it, then probably definitely that calls for an in-person treatment. But again, assessment and all, it's, we've kind of capitalized on clinical swallow examination or clinical bedside evaluations. So I do see that in the future, all of these things with more and more evidence-based practice coming up in pairing how effective is tele-rehab as good as an in-person, rehab or in-person evaluation. If the more and more data comes in, I think we'll have more efficacy, to show that these things actually work. And, and I would actually see more and more caregiver participation. I think in a country like India, it's family centered. And I think through tele-rehab, telehealth, what we really understood is caregivers had a big part, and then they can be trained as well. And they were connecting with us more and more, and using Zoom technology, or even I think people adapted to using iPhones and iPads and anything. And, so all of this is definitely possible. And I think what I'm seeing is you can actually add a modality component like strength training or all these devices, and actually send those devices to the patients. And then I think with big data tracking and all these things coming up, all of this outcome measures and everything can be actually tracked. I only see better and better things coming up, and it's totally blended in us, just like PT and OT and other rehab disciplines. We can definitely rehabilitate speech, swallowing, and language through telehealth.
Good, very encouraging, very encouraging. Thank you, Akila. Urvashi, are you here?
Yes, I'm here.
So why it is important for other members of the MDT and the families to be aware of the cognitive and behavioral sequelae, and why they should all collaborate together with the team to improve the outcome? Why it is so important?
Yeah, I think I briefly touched upon it earlier, because as we all understand that Actually, cognition forms the basis. Maybe I'm biased, but cognition basically forms the basis of your existence. If there are cognitive issues, you are not even processing the information properly around you. How are you going to do any activity? How are you going to perform even physically? So the importance of understanding, realizing what the cognitive problems are early enough. And then also for what I find in terms of awareness, that in the recent years, you've been asking everyone last year's how you felt, what will happen in the next 10 years. I'm really hoping that it's growing now, that more and more of the multidisciplinary team are becoming aware of this. In the recent past, I'm getting a lot of physical therapists also coming out and reaching out and saying, okay, here's where I'm getting stuck in the therapy. We're doing our best, but the patient is just not moving forward. And then when you look at what are the possible triggers, what are the subtle, very subtle cognitive impairments, executive dysfunction, planning, organization, and these subtle issues are just going to interfere in therapy. So I feel if we can all work together and really chat about this, talk about this, and understand the patient of why he's not performing and to optimize his performance is very important. So I want to sensitize the whole team and be with everybody and not a little outsider who comes in a little later. And the families, of course, are critical for me because I think in India, as everyone's been saying, it's family-centric. It's a long way before we'll have multiple centers like yours, Dr. Abhishek, where patients can come in. We depend on our families. And I do find that technology has helped. And if we educate them well, I believe, and I've tried that, and have good modules and make them aware, they do come and help and we can train them to a great extent. So their awareness, the other team members' awareness to address mood and cognition is critical if you want good functional outcomes and a good quality of life.
Thank you, Dr. Urvashi. I think we have finished our 3 rounds of questions to everyone. I think we have some other people also here. I could see Dr. Manshur from Mongolia being here. Dr. Manshur, you want to show your comment, please? I could see Professor Partha Ray from UK being here. Professor Partha, you make any comments?
Yes, sorry. Thank you, Abhishek. It's been a wonderful day. Any comments? I'll be brief. I was listening to all the views. I think prevention of stroke is a strong message that I'd like to send out as a neurologist, because globally, we do not have the personnel to manage the number of strokes in 2050. I'm actually two-timing with the sort of Brazilian conference that Dr. Surya is, and also with the WHO. So there aren't enough people, be it neurologists or be it allied healthcare professionals anywhere in the world. So prevention is the key. Community participation, as we have done, Dr. Urvashi Shah quite fantastically showcasing in the last IFNR meeting, is very important. We did talk about the contribution of families in LMIC, where we still continue to maintain the nuclear family structure, because I have been dealing with indirectly families with strokes acutely in India, and there aren't any healthcare providers in the villages outside tier 2 cities. That's a reality. Now, unless we actually look at the reality, we could be talking about, a few million patients in metropolises, and that will not get us anywhere. This is a public forum, so we need to be having our feet on the ground. Neurologists need to be no longer armchair people, as Dr. Dhiraj Khurana was saying, because these are the ivory tower neurologists I've been living with for the last 27 years. But the rural population of India, 70%, does not have any idea of what a stroke is. They do not know what a stroke is. They do not know that hypertension is a silent killer. They eat salt by the buckets, not knowing that hypertension is going to kill them. Sugar in the urban societies, again, going back to colonial Britain, is basically a sign of wealth. So we are consuming processed food, e-foods with e-numbers. So I think, okay, good point. I'll be a neurologist. I'll be giving anybody within the golden hour to nectar place, but I'd rather prevent these strokes. in 30 years' time. So I think I'll be short. I can go on. I've been making notes from your wonderful lectures, but I think holistic living, rural areas, lawmakers to understand what stroke is, patients' voices, community participation, telemedicine, taking smartphones, which are there in the most remote parts of India, where I can reach them from Liverpool very easily, and not enough trained workforce for 2050. That's our target, not the stroke patient who's coming into casualty in the next 3 hours. Dr. Kurana and Dr. Das is looking after them. But we need to encourage our children to take up neurorehabilitation, not only as doctors, but as basic scientists, understanding how the brain works, as PMR, as well as for occupational, speech and language, cognitive. This is basically a growing need. We're identifying it. So there's lots to do. We have got a long, hard work ahead of us. Let's focus on the distant and not on the immediate, because the numbers don't add up. And it's time every country in the world gave that some attention. There just aren't enough healthcare providers to look after the stroke pandemic that's going to hit us like a freight train in 2050, unless we are prepared. I'm sure Professor Surya will soon call me down. I better leave before he asks me to stop. Thank you.
So we got a couple of more minutes, Abhishek. Is there anything left?
I think we can ask all of them to give a small message on the World Stroke Day.
Yeah, so could we start from the Biplab?
Biplab can't connect. He's in the hospital, some connectivity issues.
So John, could you give a one-line statement for World Stroke Day?
Let's work together for a better future.
Thank you. Manigandan.
Let's get our focus right to function and family.
Keela.
I think one thing is, even if you have a stroke, you can get treated and you can be rehabilitated even after many years of your stroke. So don't lose hope. We are there to help you.
Urvashi.
Rehabilitation really helps. Please come forward soon and find the resources, but do come forward. Rehabilitation makes a big difference.
Abhishek.
I think all we need is rehab, nothing else.
My statement is very simple to everybody who is listening is, we got the best possible treatment for the stroke. Believe in your doctor and his team and follow what he says. You will be better. So with that, Abhishek, I just wanted you to give us a brief that on this note, what I mentioned, and how do you, there is a riches of the person who comes to you that I can afford the private jet, I can go to any part of the world. How you tell him that what you are getting in this country is the best and you need not worry, what we are offering you is the best possible anywhere in the world.
Yeah, I think today in India, there are centers which can provide expertise level of care in any disease per se. We take stroke as an example. That's one. And second, stroke rehab is primarily done in familiar environment, not an alien environment. That's very, very important with the family members around them, with the touch and tender care. So you can't provide rehab in an alien environment. You can go for a surgery and come back, but for rehab, should be in your own area with your family, with the expert people around you that can deliver best possible care.
Thank you. And I've got a couple of guests here. Professor Mandasir is from Mongolia. Professor Mandasir, and wish you very best for the World Stroke Day. I'm sure you must be having had a program in Mongolia. My best wishes. We have two more prominent ladies. One is Dr. Navita Vyas, who is a PMR specialist, and she's a pain specialist, and many of our patients with the stroke who refuses to allow the physiotherapist to even touch the hand or allow them to do any therapy. So Navita Vyas, could you in a short can say that how the pain can affect and you can make them better. So just a short answer, and then I will ask one question to Sonal.
Must be in a procedure.
But he's busy in the procedure. Okay. So Sonal, we wanted to know that how do you deal with the patient with aphasia who is not able to communicate, not able to speak at all, and very frustrated, behaving aggressively. So how do you take that patient forward? Is Sonal also busy?
No, I'm there, sir. Yeah. So we try our best to see that person with aphasia in a early acute phase gets a functional rehabilitation for the communication, somewhere picture communication board, and the family should be counseled that what are the do's and don'ts, tips for facilitating communication. And we try having the family and patient-centered program so that the person doesn't feel isolated, because when suddenly someone who's earlier speaking, reading, writing, talking so fluently becomes mute or doesn't understand, doesn't speak correctly, so that's a very communication disabling part. So from the word level to the phrase level, sentence level, verbal communication also with some pictures, signs, and simple apps based we can make. So it is different person to person. That's how holistic aphasia rehabilitation goes ahead.
Perfect. I think we.
Thank you, sir.
Thank you. Navita, are you there or are you busy still? So if Navita is busy, Professor Mandashiri, you wanted to say something? Professor Mandashiri from Mongolia. So we also have Dr. Suvarna Ganvi, another physiotherapist. Suvarna is professor at Ahmednagar. So Suvarna, you want to say one line today's message?
Sure, sir. Thank you so much. Today only we have started with one research project at district level to understand the burden on the physiotherapist for stroke recovery or stroke process. And it is going to be a year-long project. So I just wanted to share with the honorable members that this is what we are planning.
All the best.
Thank you so much for
all the
giving
best.
me.
I also have Irma from Mongolia. So Irma, are you also, sorry, not from Mongolia, Malaysia. Irma, are you also having the program for the World Stroke Day? And would you like to say a one-line message for Indian community on the Stroke Day? Are you there, Irma? So anybody from the team here who is present want to say a message for the Stroke Day? I will be very happy because we got exactly 30 seconds, so that's fine. If not, then Abhishek will close the meeting.
Yeah, so what we have discussed today, primarily I'll just summarize it in a couple of minutes, is that the awareness, the accessibility, and the affordability of rehab has to be considered, taking into account the rural area not getting enough rehab care. Stroke prevention is equally important as stroke rehab. Should all be able to form multidisciplinary teams to provide comprehensive stroke rehab care in our setups. We should use technology, the need of the hour, which means be it robotics, AI, or newer simple methods of tele-rehab and tele-practice. And we should be able to provide continuum of care, not only acute ICUs, but stroke units, inpatient rehab units, daycare, outpatient, family and home-based rehab programs to provide long-term care to all of our patients. With this, I would like to thank all our speakers, all our panelists, all people who were delegated to access this webinar today. And I hope this will lead to some change in your practice. You will be much more aware of the stroke rehab programs available, how you can take care of a patient at home in long term. Thank you very much. Thank you, everybody, for listening.
Thank you.
Thank you. It was phenomenal.
Yeah.
Thank you.
And, good night, and I'll see you. I've got another lecture at.
Thank you. Bye-bye.
Thank you.
Yes.
Bye.
We'll come back to you with similar program in the future.
Yes,
Thank you,
yes,
sir. Bye-bye.
yes.
Thank you.
Mati, we can close the session now.